mellitus, who presents to the emergency department with a 3-day history of nausea and vomiting. She also reports excessive polyuria and polydipsia over the past 24 hours. The provider suspects that the client is experiencing DKA. So question 1, which assessment data should be collected next? So before answering the question, think about the memory tricks DKA. So pause the screen and try your best to answer this question. Okay, so let's break it down. As you recall from the full video, the memory trick for DKA signs and symptoms first start with the D. So D is for dry and high sugar, 250 to 500. And K is for ketone bodies, or ketones, as well as Kussmaul respirations, that rapid, fruity breath. Basically, the body's blowing off acetone. Now, A is for abdominal pain, and the last A is for acidosis, or metabolic acidosis. So a pH less than 7.35. Now, looking at our answers here. So we have a full set of vital signs, a heart rate, blood pressure, and respiratory rate. We're expecting Kussmaul respirations, that rapid, fruity breath to blow off all that acid from the body. The next assessment is level of consciousness, or basically that mental status, as too much acid in the body can change the client's level of consciousness. The next assessment is a blood glucose check. So obviously, we want to see how high the blood sugar is. Next is the labs, so ABGs, CBC, and a BMP, but especially the ABGs here to assess acid-base levels. Now the CBC, or the complete blood count, will show WBCs, those white blood cells. They will typically be elevated and will provide proof of presence of an infection, since DKA is typically caused by an infection. And lastly, a BNP will show critical electrolytes, specifically potassium levels. Now, very lastly, a urine analysis can be done to assess for ketones in the urine. Now, moving on in our case study, the assessment findings, we have a blood glucose that is 1200. Wowza! So normally it's 70 to 110. So over 1,200 is intense. Now the heart rate is 110 and regular, so that's a little fast. Now the BP is a little bit low, 90 over 58. This is from the dry body. So remember, 120 over 80 is considered normal range. So anything less than 100 systolic, or that first number there, is very alarming. The next assessment finding is a respiratory rate of 34 that is labored. So it's very fast because normally it's 12 to 20 respirations per minute. And the key word here is it's labored. So it's very possible this client has these Kussmaul respirations. Now the ABGs are as followed: a pH of 7.21, a PaCO2 of 33, and a HCO3 of 18. So using our marching band suit method from the full ABG video, let's break this down real quick. So step 1 is pH, because remember P for primary. So 7.21 is very acidic, as we expected with diabetic ketoacidosis. So very acidic. Now step 2 is to find that acid match based on the pH. So PaCO2 is 33. So that's base. Now step 3 is the HCO3. It is 18. So 18 is the acid area. So that's our acid match. And the kidneys here tell us it's metabolic acidosis. So just as expected from our memory trick, it's metabolic acidosis. Now the CBC revealed white blood cell count of 24,000. Whoa! So normally the WBC count is between 5,000 and 10,000. So 24,000 is super high, indicating a current infection. Now the BMP reveals a potassium level of 6.8. Now you know normal potassium is 3.5 to 5.0. So 6.8 is sky high. So remember, potassium pumps the heart. So high pumps in the heart will lead to deadly dysrhythmias like VFib and cardiac arrest. Lastly is urine analysis. As expected, presence of ketones. So remember, diabetic ketoacidosis, we're going to see those ketones. Now, the second question here. What is the underlying pathophysiology behind the client's abnormal vital signs? So pause the screen and try your best to answer this question. All right, let's break this question down. So before answering the question, always think about the memory trick here. In this case, it's DKA to recall the signs and symptoms. So look at the first D here. It's for dry and high sugar. So the correct answer is the client is dehydrated due to osmotic diuresis caused by hyperglycemia. So osmotic diuresis is the body's method for attempting to eliminate excess glucose from blood serum. So let me read that one more time. The body's attempting to eliminate that excess glucose from the blood serum. Just think of that blood as thick, syrupy mud. Just a lot of sticky, icky blood sugar. Now, polyuria is excessive urination, while polydipsia is the excessive thirst that results from fluid volume deficit. Okay, hopefully that made a lot more sense. Now, moving on to question 3. What is the underlying patho for DKA in clients with type 1 diabetes? So remember, DKA is a type 1 diabetic problem. So let that guide your thought process here. So pause the screen and try your best to answer this question. Okay, so let's break this question down. In clients with pre-existing type 1 diabetes mellitus, or just DM, there is an absolute insulin deficiency. Remember, the body's killed the beta cells within the pancreas that normally produce insulin. So now the body can't produce insulin. Under normal circumstances, periods of stress such as illness, catecholamines are released, leading to an increase in blood sugar. Remember, during stress, we have an increase in sugar. So in clients with type 1 diabetes mellitus, stressful conditions cause an increase in blood glucose, but without insulin to counteract that hyperglycemia. Those are some big key terms right there. There's no insulin to bring down that sugar, so we get hyperglycemia. This client presented with a 3-day history of vomiting, suggesting that the underlying illness initiated this client's DKA. Now, moving on to question 4. What do this client's ABGs reveal and what is the cause? So once again, pause the screen and try your best. All right, let's break this question down here. ABGs reveal metabolic acidosis, as stated before. The metabolic acidosis that's seen in clients with DKA, big key terms here, results from lipolysis, or basically a breakdown of fat for energy. The body switches from using glucose for fuel to using fat for fuel. So when fat is broken down for energy, these fatty acids are converted to keto acids, leading to a state of metabolic acidosis. So yes, kind of like going from clean electric energy within a car with no emissions when using glucose for fuel, and then switching to that dirty diesel that pollutes the body with those ketones when we're burning fat for fuel. Now lastly, question number 5. What is the body's method for compensation for metabolic acidosis? So remember, compensation is the body's way of balancing itself, or basically finding that common ground of compensation. So pause the screen and try your best to answer this question. All right, so let's break it down here. Remember the key term, Kussmaul respirations. The client hyperventilates in attempts to blow off excess carbon dioxide, that's CO2, which I call carbon diacid, since all that CO2 pushes the body into that acidotic state. So the goal here is to bring the body from an acidotic state to normal pH balance by breathing off all that CO2 out of the body. So those Kussmaul respirations try to get the body into balance.